All right, so let's talk about what pronation and supination is. If you are somebody that believes that pronation is something that we need to limit or get rid of, pay attention, because I'm going to show you why pronation is imperative. And if you're somebody who believes in overpronation, pay attention, because I'm going to tell you why overpronation does not exist. So if you have patients that have pronation control problems, which is definitely 100% real, this is the thought process that you need to implement when you are seeing these patients and you're trying to help them be better at pronation control, so they actually control pronation, get into it, and then get out of it with supination. So the easiest way to see pronation and supination is with a single leg squat. So what we're going to have Cole do is do a right-sided single leg squat. So when he comes down, he's going to pronate. Now, pronation and supination just isn't a foot thing. It is a knee and a hip thing. So when he goes down, his hip is going to internally rotate, adduct, and flex, which is the three components of pronation. His knee is going to internally rotate, adduct, and flex, pronation. His ankle and his foot are going to adduct, internally rotate, and flex. That is pronation. That is what needs to be controlled. Now, remember, pronation is loading. It is an eccentrically controlled motion because of eccentric contraction of the muscles that control pronation. So as he is going, eccentric means he is going down. The muscle is lengthening under control. So if I look at Cole's vastus lateralis, let's say this is his vastus lateralis right here, which is a quad muscle. As he goes down, that is lengthening. As he goes down, he comes up, it shortens. So if it's lengthening under load, that is eccentric. Shortening under load, concentric. So pronation, flexion, internal rotation, adduction, lengthening, eccentric control. If he cannot do that, then he pronates too far, too fast, and that is what people mistakenly call overpronation. Overpronation, when you're talking about feet, would mean that if we watch his navicular as he goes down, navicular drops. So overpronation would mean his navicular would go through the floor, which is impossible. So there's no such thing as overpronation. There is pronation too far, too fast without supination. So this is not overpronation if he collapses too far, too fast. This is under supination. So if he does not come back, that's a problem. And the reason why he doesn't come back is because he does not eccentrically control this. His soleus is not eccentrically controlling tibial anterior translation. So those things collapse too far, too fast. Now he's got too much weight going down. The muscles that aren't loading can no longer unload, which means he can't supinate. So he's failing to control pronation, which means he's failing to supinate. That's the problem. Overpronation is not a problem. And stopping his foot from moving by putting some kind of an arch support or something there totally screws the whole thing up, because if I put his arch support there, now I'm blaming everything on his foot. I'm not looking at his knee, I'm not looking at his hip, and if these are the problems, we can stop pronation at his foot, which is a terrible thing to do because he can't load at all, and we didn't assess and treat the problem, which could have been here. So if this is the problem, and it goes too far, too fast, now it can't unload, so this is on slack when he tries to unload, that's a major problem. If I facilitate his vastus lateralis, and most likely his gluteus medius and his soleus, then he can load appropriately, which means he can unload appropriately, and we didn't have to screw his foot up by putting some piece of garbage there that the textbook would tell you needs to be there. The other point here is there is no flat feet, high arch, whatever. His mechanics, his genetics are going to dictate what he does. So people with flat feet also have knees and hips that have bony morphology because of their genetics that match their flat feet. So if you try to take somebody who has a flat foot and make them have a high arch, you just screwed them up, because now you screwed up their knee mechanics, their hip mechanics, their lumbopelvic mechanics, because you tried to make them look like the book, which is never going to happen. Everybody's Genetics are going to be unique. Everybody's presentation is going to be unique. And if you don't get them to function the way that their genetics and their bony morphology dictates they need to function, you just screwed them up. So I can tell you that every single day when I see new evals and they come in with arch supports in their shoes, we get rid of those. And they tell me, but I have plantar fasciitis. And I ask them, well, if you take your arch supports out and you walk without your shoes on, do your feet hurt? Well, yeah. Well, guess what? You still have plantar fasciitis. If you've been wearing arch supports for 20 years because you have plantar fasciitis and flat feet, you still have that same problem. Now, on top of that, you have low back pain because now you're not loading and unloading through the lower extremity. You're pounding all of that pressure onto your lumbopelvic region, and that's why you have low back pain. If we toss the orthotics, we fix your biomechanics that are specific to you. Now your foot functions, your knee functions, your hip functions, and we unload your lumbar spine, and guess what happens to your low back pain? It goes away. So if you are a physical therapist and you don't know how to assess pronation and supination, if you don't understand that it happens throughout the entire kinetic matrix, if you don't understand how to assess each individual muscle that should be loading during pronation, and then reverse inhibition, then you don't know what you're doing with your patients, and that's what you should have learned in PT school, but you didn't because that's not on boards. So when you're ready to learn how to do that, let me know, and I'll teach you how to do all of this so you can apply that with your patients.